You know, appropriately, we're increasingly focusing on the importance of tricuspid regurgitation, secondary tricuspid regurgitation. There's nobody better to talk to us about that than Pat McCarthy from Northwestern. Pat, thanks.
Thanks, Randy.
So, the concept of functional TR and how we diagnose it and approach it, I think, is increasingly important. So, question is, how do we diagnose it?
So, the standard way of just looking at the TR jet, and when you're there to operate on a mitral or other valve, then you go ahead and fix it at 3 to 4 plus. That's just standard of care. The new stuff that is more interesting is, to intervene early, because we know that it doesn't go away in the vast majority of patients, especially cardiomyopathy, and even now just including tricuspid annular dilatation. Gilles Dreyfus did an interesting study years ago showing if you have tricuspid annular dilatation with trivial or no tricuspid regurg, that if you study those patients that aren't treated, that the TR progresses and it's a problem.
So Pat, let's talk about functional TR, secondary to which is the vast majority of it. So in mitral valve disease or in LV dysfunction, is it a pure annular or is it an RV papillary annular problem? What is the problem?
It's just like functional mitral regurg. I really think of them as being like symmetry, right and left sides. So it is not just the annular problem. The annulus is dilated. That's just where we intervene the most because that's where we have the tools. That's where we can do the annuloplasty or put the ring. But the underlying problem is the dilated right ventricle, frequently from pulmonary hypertension, tethering of the papillary muscles and the cords, and really that's what's pulling those leaflets down in addition to the annular dilatation and creating that problem.
So do you diagnose? So you're measuring annular dimensions, aren't you? You're doing that on echo, transthoracic and TE.
I do. So every intraoperative transesophageal echo in a patient going through mitral valve surgery now, I have my team trained that they get in there and we do the tricuspid annular dimensions. And in fact, it's actually gotten very good so that if they see my name on the referral on a pre-op echo, they get me the tricuspid annular dimensions.
And they're measuring those at where and when?
Well, what we look at is the commissure between the anteroseptal and then the anteroposterior, which is the widest part, the maximum dimension across the valve. And the annulus actually turns circular. It's not so much the normal ovoid. And so they can do it in a variety of different ways. And I actually measure it directly myself. It's going into our database, and they're very good at it. They actually get it within a couple of millimeters.
If I'm not mistaken, the European guidelines, or people have talked about 40 millimeters or so. Is that the size that you will go ahead and do it? Or what I'm getting at is that what size do you use?
So the European guidelines say that at 40 millimeters maximum diameter, you should consider tricuspid annuloplasty if you're already there for mitral surgery. They don't say that you have to do it, and I view it as a little bit of wiggle room. If I get to 45, then I'm almost surely going to do it. If it's at 40, there's no right heart failure, it's an older patient, a little more complex surgery, I may just leave it alone. But if it's a young patient and is 42 or 43, and in particular before surgery, I ask them about that history of ankle swelling and any symptoms of right heart failure, then I have a very low threshold to go ahead and fix it.
And Pat, you're using complete rigid rings, is that right? I mean, we've learned that's best, isn't it?
So there have been a variety of ways to do it. There's the suture annuloplasty, most commonly the DeVega, but also including the K annuloplasty, and then just flexible rings. And then a study from the Cleveland Clinic when I was there, but then also more recently by Jose Navia shows that the complete remodeling, more rigid rings actually work the best. And by way of disclosure, I invented the MC3 ring. I'm the MC3 is three-dimensional. So.
Let me ask you another question, though. do you ever get into, because I think Giles talks about that you could have tethering of leaflets or abnormalities and coaptation, like we do with mitral, coaptation distance. Is that an issue?
So it is. I don't think we should be 100% repair in everything. I think there are some patients where you just, a good replacement is safer than a bad repair. We do know the recurrence rate for patients with a lot of tricuspid tethering and a dilated right ventricle is pretty high. And so that's a group of patients where I'll do a bioprosthetic valve replacement, cord sparing, like what you do on the left side.
Okay.
So you preserve that subvalvular apparatus and the valvular ventricular interactions.
So and last question I have for you, because it's an interesting question. I've seen about 3 patients who have all had excellent primary mitral valve repairs for degenerative disease 10, 12 years ago, and they have now come back with very intact mitral valves, but the tricuspid valve is annulus is big. They've got florid TR. So it's really a biannular, bivalve disease, isn't it?
It is, and that's a not uncommon clinical scenario, and it's a problem, and it just points to why we're moving the bar towards earlier intervention, because patient may not have had much tricuspid regurg at that first operation, but had annular dilatation, and if you put a ring in, you won't have to deal with that operation a second, which is a tricky operation.
So in today's, this is knowledge that we've gained over a period, because a lot of people didn't do, they weren't 10, 12 years ago, were you routinely putting in tricuspid rings?
Not like I do now,
right, okay.
But the thought has really evolved. Nina Bromwald in the 1960s said, if you just fix the mitral, PA pressures drop, tricuspid regurg resolves, and for years we lived with that, but we weren't really doing echoes and we weren't really checking our results.
Yeah.
And then once we started following, we started to evolve our thinking, and I used to do lots of heart failure, cardiomyopathy patients, and that group in particular have that ongoing RV dilatation, and so they're really at risk for developing TR. So it was somewhere around 10 to 15 years when we started looking at low EF mitrals that we started to pay more attention to the tricuspids.
Super. Listen, thank you very much for joining us.
Okay, Randy.
A lot of good information. Thanks.